Today we're going to talk specifically about GERD. GERD affects over 10 million people. In 2009, almost $9 billion was spent, $9 billion was spent on office visits for GERD. So that's a huge number, and it's a huge problem in the United States, and I'm assuming that's why most of you are here to hear more about GERD and some possibly new upcoming ways to treat that. So what is GERD? First of all, I think the first thing we should talk about is gastroesophageal reflux without the D, so just GER. And everybody has gastroesophageal reflux. That's reflux of the gastric contents into the esophagus. That happens a few times a day for everybody, and most of the time it doesn't cause any problems. When it does, it becomes GERD with the D, and that's a disease where the normal protective mechanisms that the body has in place are no longer effective in controlling that reflux from the stomach into the esophagus. And that can cause problems, it can cause symptoms, it can cause long-term complications. So we think that we really don't know how many people have GERD because there's probably, a lot of people who don't ever complain of heartburn, who don't ever complain of GERD to their physician. They just think that's something that's normal. Their parents had it when they were growing up. They pop some Tums or some Rolaids that are now back on the market. And they say actually just happens to me when I drink orange juice or when I eat too much chocolate or when I have spicy food, and it's not a big deal. I just pop Tums, so you find yourself popping more and more and more Tums. But we think probably about 40% of the population has GERD. 10 to 20% of those people have daily symptoms. And not, a lot of people don't have daily symptoms. A lot of people, those are the people that don't take medications, that don't come to the doctor to talk about it. But there are a significant portion of people who have daily symptoms that does affect their life. We talked a little about symptoms of GERD already, heartburn, and that feeling of regurgitation from the stomach up into the esophagus, that's into the middle of the chest, and burning type pains. Long-term problems with GERD, the next point hits, breaks, erosions in the esophageal mucosa. That's when the acid starts to damage that lining of the esophagus. And people can have more frequent symptoms, more severe symptoms. But we commonly see people who we do an endoscopy for other reasons, and they don't really complain of GERD, they don't complain of heartburn, and we look in there and they have erosions or small ulcerations at the end of the esophagus that they didn't even really know they had. So some people have silent GERD, silent reflux. And long-term complications of GERD, uncontrolled reflux ulcerations, damage to the esophagus lining can cause things like Barrett's esophagus. Barrett's esophagus can be scary. We'll talk more about that later and some complications of GERD. So why do people get GERD? We talked about it earlier already that everybody has reflux. It's normal that happens. We have relaxations in the lower muscles of the esophagus called the sphincter. And one of the working theories of why people have GERD and why some people's is worse than others, they get the disease associated with the reflux, is that muscle at the bottom of the esophagus is faulty. It doesn't stay as tight as some people's. We don't know why. But that muscle keeps the bottom of the esophagus pinched off so that the acidic contents from the stomach can't just continually reflux back and forth. There are normal relaxations of that muscle called transient lower esophageal sphincter relaxations. Those are normal, and that's why we do get some reflux, but it's not normal to have that constantly for that muscle to not be tight and protecting the esophagus all the time. Another cause of GERD is a hiatal hernia. Some of you may have had an endoscopy, may have had an imaging study. They tell you that you might have a hiatal hernia. What a hiatal hernia is when the top of the stomach comes up above the diaphragm. The diaphragm is the muscle that goes across, that separates the abdominal cavity from the chest cavity. And there's supposed to be a hole in the middle of the diaphragm where the esophagus comes through, and that's where those muscles that we were talking about earlier, they try to keep the bottom of the esophagus pinched off so that the acidic gastric contents can't come back up and damage the lining of the esophagus. So hiatal hernias don't always cause a problem. Just because you have a hiatal hernia doesn't mean that you're going to have gastroesophageal reflux disease. So we can see people who have large hiatal hernias who we find incidentally, and they'd say, well, I've never had a problem with that before. I didn't even know I had it. And then we have people who have very small hiatal hernias who have terrible reflux disease, terrible complaints of heartburn all the time. So just because you have a hiatal hernia doesn't mean you're going to have reflux, and the size of the hiatal hernia doesn't really correspond all the time with severity of symptoms. Finally, things that can cause GERD, which many people are aware of, are lifestyle choices and dietary choices. We think about, a lot of people have trouble with acidic things like tomatoes, like citrus juices, caffeine, chocolates can be a trigger. But I think most of us are aware of those things, and we try to avoid those if we have a problem, or we take antacids over the counter or something if we know we're going to have a heavy red pasta sauce or something like that. Frequently we hear about that in the office. So what are the symptoms of GERD? Heartburn, acid indigestion, painful burning sensations in the throat or chest. Now, I think we should stop here. And before we continue talking about GERD, if you're having painful sensations in the chest, the first thing we need to think about is not GERD. The first thing we need to make sure we're not having is a heart problem. So please don't, just because you always have GERD, don't think that if you're having new or worsening chest pains or something feels different, don't just chalk it up to GERD. Okay, be evaluated, go to the emergency room, call your doctor, but it doesn't do a whole lot of good to treat your GERD if you have a heart attack. So that's more important, and we should always remember that. You can have extraesophageal manifestations of GERD, meaning not the typical food pipe esophagus complaints. You can have chronic cough, wheezing, asthma, difficulty breathing. People can wake up in the morning feeling an acidic taste in their throat. Clearing your throat a lot in the morning can be a sign of uncontrolled acid reflux during the nighttime when you're laying down. An alarm sign of GERD would be trouble swallowing. We call that dysphagia. Or painful swallowing, called odynophagia. Both of those are long-term problems. Can be complications of GERD, though we call those alarm signs. And if you're having problems swallowing, if you're having pains with swallowing, that's something you definitely want to let your doctor know about, so they can send you to somebody like us to evaluate that. I mentioned the sour, bitter taste in the mouth, metallic taste, some people say. Excessive belching can be a sign of GERD. Excessive salivating, we call that water brash. That's one of the body's compensating mechanisms to try to combat the reflux of acidic contents coming up. Your body's remarkable. It knows that there's something going on in the esophagus. It knows that there's too much acid. So you're secreting more saliva that you swallow down the esophagus to try to help the body clear that acid out and reduce the acidity level, increase the pH in the esophagus to prevent acid damage. And tooth erosion is also a sign of GERD. That would be pretty bad. It's coming up into the mouth. But dentists can notice tooth erosion and can alert you that you're having, tooth erosion. Not sure what you might want to go get checked out for uncontrolled reflux disease. And some of the dental, this is just an aside, but there's some good charts on some of the dental association websites about acidic drinks. We don't have a slide on this today, but you would be very surprised if you check out some of the dental association websites. on acidity of drinks that we normally drink, you'll be shocked at how acidic some of the most common things that we drink are, especially diet sodas. The pH is almost as low as battery acid in some of those. Not quite, but it's a lot farther away from normal than you would expect. So what can you do about GERD? Well, the first thing that we always want to talk about with any medical problem is what can we do from a dietary perspective, from a lifestyle perspective, to try to combat our medical problems, and GERD is no different than that. So one of the big reasons people have GERD and people with worsening heartburn, you'll notice that as you gain more weight, a lot of times those problems get worse. So one of the first things we want to tell people is, if you are carrying extra weight, then let's try to lose some weight. That may help your GERD, but there are plenty of normal weight and underweight people who have reflux too. But we should always start with lifestyle modifications. Stopping smoking. Smoking relaxes the lower esophageal sphincter, so stopping smoking can definitely help your GERD and heartburn symptoms. Elevating the head of the bed by 6 inches can help. Doesn't help everyone, it can help, especially if you're having those nighttime type symptoms. And when we say elevate the head of the bed, I have a lot of people who come into the office and say, well, I sleep on multiple pillows. Well, that doesn't really help, because you're basically, by the end of the night, you're just bending your neck down, and that's not really increasing the incline on your letting gravity help you. It's not. Most people just, you can't, unless you have one of those big, huge wedge pillows that are really, really uncomfortable, you're really not going to help yourself unless you put 6-inch blocks under the front posts on the bed. We always tell people with GERD, don't eat or drink 3 to 4 hours before bedtime. Now, you can have water, but you don't want to come home at 8 o'clock at night, have a big, heavy meal, and then go lay down in bed and go to sleep at 8:30 or 9 o'clock. It may make you sleepy if you have a nice meal, but it's not a good idea. It's not a good idea to eat that closely to bedtime. Eating slowly and chewing slowly, I think that's probably just a way to avoid overeating more than helping your reflux. Because if you eat slowly, you chew slowly, you're going to get full quicker. You probably would tend to overeat less. And that's probably why that may help GERD. Because overeating stretches out the stomach, stretches out that lower esophagus sphincter, and allows more reflux to happen after you eat. So avoiding overeating is important. Trigger foods, fatty and fried foods bother people, alcohol, chocolate, coffee, and coffee just fits in the caffeine category. Spicy and acidic foods are not on there, but they should be. Avoiding tight-fitting clothing puts pressure on your abdomen. We don't have too much of a problem with that in the older population. Some of the young females try to wear tight clothing, males too, and they come in with terrible symptoms, and we get them to loosen up a little bit, and that can help. Although I'm not sure that helps as much as a lot of the other things on the list. So once we go through lifestyle modifications, dietary modifications, and those don't help, then it's time to turn to medical treatment options. So what are our medical treatment options? Well, the first thing that most people turn to is they head to the pharmacy, to Walmart, Walgreens, CVS, Publix, and they grab some Tums or some Rolaids or some Mylanta, and they take that after they eat when they're having symptoms, and it can control that acid pretty well. The problem is it doesn't really do anything to the underlying problem. It's just sort of controlling the symptoms as you get them. It's not helping you prevent anything. But they do work great. If you find yourself using more and more of those, it may be time to talk to somebody about your reflux. Also available over the counter are H2 receptor blockers like Pepcid or Zantac, and proton pump inhibitors, which are the newer class, and those are things like Prilosec, Prevacid, those type of medicines. So the difference between the proton pump inhibitors like omeprazole, Protonix, Nexium, over-the-counter versus prescription strength is just the dosing. So the over-the-counter availability is half of the dose of the prescription strength products. The H2 receptor blockers work great. You can take those when you're having the problem. And so they're a good over-the-counter medicine for GERD because you can, if you're having heartburn, if you're having reflux, if you're having GERD, you can take a Zantac or a Pepcid or a Tagamet, and it can control that acid quickly. But on the other hand, the proton pump inhibitors like Nexium, like Prilosec, in that category, if you're having a problem right now and you take that and you take one of those medicines, it's not going to help you. So these medicines help by shutting off what are called proton pumps, which make acid, but they don't work immediately. They take time to work. So having omeprazole or Nexium on hand from the drugstore and just treating as needed is just, it's not going to work. You can treat as needed with the antacids like Tums and Rolates, and you can also treat as needed with the Zantac and Pepcid. But the PPIs, the proton pump inhibitors, are something that you have to take regularly to try to prevent the problem. So prescription medicines, the top two there, the H2 blockers and the proton pump inhibitors we talked about, and the prescription dose is double the dose. And there are a couple of proton pump inhibitors that aren't available over the counter. But the studies have shown that there's really no, the drug companies like you to think there are, but there's not a definite benefit to any of the ones in the class. So, I don't know that you need to spend more on an expensive PPI to try to get a better result. Some of them are just formulated differently, so you may not have to take it 30 minutes before food. But most of the proton pump inhibitors, you should take 30 minutes before your first meal of the day. You can't, if you take it with food, it's not going to work as well. And we frequently in the office see people that are not taking their omeprazole, which is Prilosec, their Nexium, those PPIs at the proper time. So 30 minutes, I usually just say breakfast, but then I've had a lot of people tell me they don't eat breakfast, so I say before your first meal of the day. And then some people do use baclofen, the last prescription to strengthen the lower esophageal sphincter. So baclofen is available and it does help, but not a whole lot of people use that medicine to treat GERD. So we've tried the lifestyle modifications, we've tried the prescription medications, we've maybe even doubled you to being on a PPI twice a day for your GERD symptoms, which is not technically indicated for, but it does help some people. Maybe we've tried you on a proton pump inhibitor in the morning, and you're telling us you're having a lot of nighttime symptoms, so we say, well, why don't you try to take Zantac before bed to try to control the nighttime symptoms in addition to the omeprazole or Nexium in the morning. And they come in and say that's just not working. So there are surgical options. Reflux surgery is not something to be taken lightly. It should be used on people who really are having significant lifestyle problems due to the GERD. And some of the available procedures are Nissen fundoplication, which can be done laparoscopically, and now should probably always be done laparoscopically. Those are just, laparoscopically means the little tiny poke holes that they use the long scopes to go through your abdomen instead of making a big, huge incision. And what a Nissen fundoplication is, or any fundoplication, is they wrap the top of the stomach around itself to try to reinforce under the diaphragm where that lower esophageal sphincter is. And there is good success with that. There are definitely side effects to that. You have trouble belching or vomiting if you have a problem. And you can also have trouble swallowing after that if the wrap is too tight. They try to wrap it over a certain diameter dilator, but some people still do have trouble swallowing after that surgery. And with any surgery, there are complications with anesthesia and all those kind of things. A newer device is called the Lynx device, and those are magnetic beads. That's what this picture is. This is the Lynx device. That's also done by a surgeon, and those are magnetic beads that link together, and they help reinforce that lower esophagus. It's a newer surgical procedure. It's still a surgery. You still have to get put to sleep to do it. So we don't have a lot of long-term data on it. It does help people with the reflux symptoms And we'll have to see more on long-term data. The scare for me is erosions. We've tried lap bands and things like that in the past, and now we're long-term, we're having trouble with those eroding through. And we're going to hope that the Lynx doesn't have problems like that. It's for a different problem, but it's still a foreign body inside of our body, and we don't know what's going to happen long-term with those. So we have you on medication, and it's just not working. So surgery would be an option. If you're on an EPI or on an H2 blocker and things aren't helping you, then you definitely should see a gastroenterologist to take a look with an endoscopy to make sure there's not something else causing the problem. See if there's anything we can do to help that out. Complications of GERD. I told you we would talk about complications. And part of the reason that we even care about GERD is heartburn is treatable with Tums, with Rolaids. We know we can do that. That's what everyone runs to. The problem with that is there are long-term complications of GERD, and that's why we want to try to prevent the problem from happening rather than just masking the symptoms every time it does happen. So what can happen because of long-term reflux damage? Number one would be esophagitis. Esophagitis is inflammation in the bottom of the esophagus. So the acid comes up, it starts to erode the bottom of the esophagus, and then you can start to get ulcerations in the esophagus. That can cause pain, it can cause bleeding. It's a big problem. We see a lot of people in the hospital with esophagitis-related issues. So we'll skip over Barrett's for a second, and we'll go to strictures, because I think that the strictures are more related to the esophagitis. You have esophagitis, you have the ulcerations, there's inflammation in the esophagus. And what does the body do when you have inflammation? You can think about when you skin your knee or your elbow and that skin grows back, it makes a little bit of a scar. It gets a little tighter than it used to be. There's some fibrotic tissue there. It's not as stretchy as the rest of your skin, not as stretchy as everything used to be. And that happens in the esophagus too. So it's a different skin, but the body still works relatively the same way. So we've insulted the esophagus, we've had inflammation, erosions, ulcerations. That heals up. We're pretty good at healing that, putting you on the right medications and healing that up. But then comes the next complication. Not everybody gets it, but you can have strictures of the esophagus. And that's where the esophagus gets too tight. That can lead to problems swallowing. We can fix that too. We can stretch out your esophagus. But if we can prevent the GERD in the first place, if we can keep you from having those complications of reflux disease, then we can probably prevent the stricturing. There are other reasons to have strictures besides GERD, but commonly strictures are from GERD. And then now we'll talk about Barrett's. Barrett's esophagus right here. So Barrett's esophagus is due to long-term reflux damage. And it's when the esophagus lining changes into a different kind of lining that's not supposed to be found in the esophagus. So you can have just plain Barrett's where you have intestinal metaplasia, meaning intestinal mucosa that's not supposed to be in the esophagus. It's a different lining. And that can be very benign, and you can just have that metaplasia. But then it can advance to what we call dysplasia. Dysplasia is bad. So you can have low-grade dysplasia or high-grade dysplasia, and then finally you can get to esophagus cancer. So the complication that we're talking about is long-term reflux causing esophagitis, causing Barrett's esophagus, and then that Barrett's esophagus turning into dysplasia, which if you have Barrett's, we would hope to find you before you make it all the way to esophagus cancer. If we find Barrett's esophagus with dysplasia, high or low-grade dysplasia, we have therapies to try to treat that and convert you back to a more normal type lining that doesn't have that risk of esophagus cancer. So it's very important to not discount your GERD symptoms. And it's very important to try to continuing to work on therapies that can prevent the problem from happening in the first place rather than fixing it once we have a problem.